Another series of Public Health 101. Today we're going to be hearing about the Health Equity Zone Initiative. So Mia and Jen, if you'd like to introduce yourselves and we can get started.
So hi, I'm Mia Patriarca. I'm the Health Equity Zone Program Manager, and Jen Latham, our HEZ Evaluator, will introduce herself in a second. I've been with the department for over 25 years now. I have a background in community organizing as well as public policy, and I have, in my time with the department, I have focused my work on building community capacity, so to address social and environmental determinants. So thrilled to be working with HEZ. So Jen.
Hi, so I am Jen Latham. I am the evaluator for the HEZ initiative, and one of the newer members of the team. I've been here about 1.5 years, and I'm excited to go through this with you.
So next slide. So research has demonstrated that approximately 80% of our health is determined by factors that are outside of the clinical setting. And so you can see, looking at this pie chart, we're looking at social and environmental factors driving about 40%, in the aggregate of health outcomes, physical environment, 10%, health behaviors, about 30%. And you can see that clinical care and as well as genes and biology only make up about 20% of the factors that determine our determine health outcomes. So, based on those findings, 10, 15 years ago, public health, in recognition of this information, started to make a shift in terms of where we're making our investments. So we started to shift some of our investments away from individual treatment and prevention and towards strategies that address social, environmental, and economic determinants of health. That doesn't mean that individual strategies investments in prevention don't work. They do. They're part of the puzzle, but that broader factors that were influencing health outcomes just were not getting the kind of attention that they should have been getting. So we changed our focus. So next slide. So, again, in recognition of this relatively new information, RIDOH, under the leadership of Anna Nabaish at that time, in 2012, made some changes in terms of investments in community capacity building. So we launched a series of initiatives to build a portfolio of investments at the community level, starting with what we called the Centers for Health Equity and Wellness, otherwise known as CHEW grants. CHEW grantees were provided with funding to develop, implement, and/or scale an initiative that would address social and environmental factors within their community. Some examples of CHEW projects were efforts that addressed food access, chronic disease prevention, active transportation, recreation enhancements, asthma prevention, and early childhood development. So some of the differences, though, between these early sort of, if you will, experiments with really doing some comprehensive community capacity building was that they were a bit more kind of topic area focused, and they were not necessarily geographic. They didn't necessarily have a geographic focus. So, based on these learnings, next slide, please. We launched the Health Equity Zone Initiative. Excuse me. HEZ is health equity centered, as the name implies. It's place-based, so it's centered on a geographic area. It's community-led, and it focuses on social and environmental determinants of health. So there were, a few learnings that from the CHU experience and other community capacity building efforts that that we brought into the HEZ initiative. One of those was that the public health's kind of history, let's say, of determining priorities on behalf of the community inhibits the ability to operationalize an equity approach. Regardless of our intentions, it's inherently top-down and inefficient, ineffective, because solutions to broader health challenges lie in a partnership between public health and communities. So, we as public health professionals had and probably still do have a history of sort of looking at the data, looking at health outcomes in a community and sort of saying, well, your problem is X. You have a high rate of diabetes. You have high rates of overweight, et cetera. And and then in prescribing solutions here, we're going to give you X amount of dollars to focus on physical activity and access to healthy foods because of this data. And where the community may also share those concerns, that might not be their highest priority. They may be more concerned with modifying the physical environment in ways that promote a safer place to walk. So what we might be emphasizing in terms of programmatic efforts around physical activity may not fit with their what they see as their problems and what they envision as solutions. Also, social environmental conditions are systemic in nature and require a comprehensive approach. For example, food access is impacted by cost, physical location, consumer preferences, cultural appropriateness, the right kind of food, et cetera. So trying to solve one piece of that issue, which is what we typically do, when we're launching programs, doesn't address the systemic needs that are driving food insecurity. So that point also kind of speaks to the my earlier point in terms of are we aligning with what the community sees as the problem. Another learning was that most community-focused investments provide resources for the implementation of projects and programs, but not for the programs and partners in the community to work together to drive sustainable, long-lasting change. So really, the power of collaboration is key. And when we work in silos with just a handful of programs or organizations or individuals that focus on a topic area, we don't get that coming together and the kind of value add that we see through HEZ by pulling together a broader array of stakeholders who can really marshal resources and mobilize support to address specific issues. Also, another learning was that program-centered approaches to health or grant-centered approaches to health improvement follow a boom and bust life cycle that's not conducive to long-standing change. Projects start up and launch, 2 to 3 years of implementation, with another year of maybe a closeout. Just doesn't. It's enough to build something that might be starting to be effective, but then we pull the money and then we expect them to find other money elsewhere, magic money that doesn't necessarily appear. So that strategy is something that we're trying to get away from as well, which, and so one of the things that we emphasize with HEZ, and that, we are really focused on doing the fundraising to support, is the idea of a long-term commitment to this work, so that these kinds of efforts can be nurtured and sustained. So next slide. So as I mentioned, we launched the Health Equity Zone Initiative about 8 years ago now, going on 8 years. Communities were able to apply for HEZ funding through a competitive request for proposal process, an RFP process that called on applicants to identify a geographic area that was representative of what the community saw as a contiguous area that had its own identity. So, one of our HEZs is based in West Elmwood, the 02907 community. We have a South Providence HEZ. We have a Central Providence HEZ that's a mix of neighborhoods that are contiguous. So they're side by side with one another, and they make up sort of a region of Providence. I'll show you a map in a couple of slides, but we have, HEZs. Some HEZs are entire counties, which, at this point we feel might be a little too large. But, some of them are municipalities. Some of them are small regions of municipalities. So, the geographic area, again, is determined by the applicant, and again needs to present a certain identity. So the next step in building a HEZ is once they're funded, the sort of initial group that applies will then build a collaborative of a variety of stakeholders in the community that represent community-based organizations, municipalities, including police, fire, elected officials. Typically, our HEZs also include some statewide organizations and residents. And residents are a very important part of HEZ. A number of our HEZs, in fact, most of them pay residents to take part, and that has, they've determined that that's a lot more sustainable. It's not really equitable to expect residents to, participate for free when others are at the table based on salaries. So, so the collaborative is an important next step. This group will then conduct a pretty comprehensive community needs assessment. So they'll look at existing qualitative assessments. They'll look at the quantitative data. We'll help them with that. They'll be looking across a wide variety of information sets. So, everything from, core health outcomes, like infant mortality, like, rates, rates of diabetes. They could be looking at teen pregnancy, et cetera. But, they'll also be looking at education outcomes. They'll be looking at other indicators around education. They'll be looking at housing. They'll be looking at behavioral health, et cetera. So there's, again, very comprehensive, looking broadly at the needs, but also the assets of a community. So what are some issues and problems and challenges, but then what are some assets that this community already has in place that could be leveraged and deployed towards solutions. So, in terms of the community assessment, they could be doing surveys, focus groups, key informant interviews. A lot of our HEZs have done some very creative, used some very creative methods to do assessment. All of our HEZs now, we've, as I mentioned, we've been in place for almost 8 years now. We have some of our HEZs that have been with us that whole time. All of our HEZs take part in mentorship so that they're sharing their learnings with one another. So, some of the creative ideas that our HEZs do in their first year around doing this deep dive assessment, will be shared with up and coming HEZs. The assessment process is continuous though, and is updated on a regular basis, but it's most intense in the first year. Once they complete that assessment, they will identify themes and work with the community to prioritize what are some of the issue areas that the community wants to act on first. So, they'll typically organize some give back sessions and have that conversation, use some sort of a technique like sticky dots or, various other ways of helping the community determine what are the most important issues to act on first. And I'm sorry, my screensaver popped up. 2 secs. And then based on these needs that based on the priorities that the community has identified as areas of action that they want to act on first, they'll use that information to develop an action plan that will have goals and strategies and activities and outcomes and and then that will be the implementation of the action plan will begin at the beginning of the second year. So next slide. Skip this one. All right, so this shows the current state of the state in terms of HEZ. Right now we're in, we have 15 health equity zones. And as I mentioned earlier, you can see that some of our HEZs, encompass an entire county. In this case, it's Washington County. Some of our HEZs are neighborhood based, as you can see in this Providence cutout of the map. And some of them are in smaller regions, like our Blackstone Valley HEZ, which is North Smithfield, Lincoln, and Cumberland. Or a municipality like our Warwick HEZ or Cranston HEZ or East Providence. So they serve 26 cities and towns throughout the state. There are only 13 right now that do not have or a HEZ presence. And 85% of residents in the state are served by a HEZ. And that's because these towns that are not HEZs tend to have lower populations. These are semi-rural communities for the most part. So the vast majority of state residents are served by a health equity zone. Next slide. So this just shows you representation on HEZs, what that looks like. As I mentioned, we have 15 currently. Eventually, we're looking to establish a statewide footprint, but for now, we have 15. There are over 300 health equity zone collaborative partners with an average of or a median of 70 individuals on each collaborative, including residents. And we have 20 plus sectors represented across health equity zones, including businesses, social services, faith-based organizations, healthcare, education, municipalities, etc. So wide variety, and the membership of each collaborative is mostly determined by what kinds of issues that each HEZ is working on, and it changes over time because for instance, because of the pandemic, many more of our HESs are getting involved with addressing affordable housing, and you know, they're having to engage or further engage the housing sector. So they're adding additional partners. But, you know, as HESs again take on new issues, new priorities, they'll take on new partners, and sometimes, you know, some of our partners are, you know, when it, perhaps a project is over, or you know, they're pulled in a different direction, they may also drop off the HES. So, you know, there's this constant cycle of renewal. So just go back to that one sec. Sorry, Jen. So I just wanted to mention, I think I just mentioned earlier, that we're aiming to have a statewide footprint. So those 13 cities and towns, or actually towns in this case, we're trying to engage as many as possible. And we recently completed a feasibility study that provided us with information on what are some of the barriers to engaging in a health equity zone, what kind of messaging, how do we need to change our messaging to engage these communities, because, you know, they're again semi-rural, they sort of think of equity differently than many of our current HESs. So we're really we're now using the information from that feasibility study to craft a new RFP that will be going out in the early spring of 2023. And, you know, we're hoping to engage a number of those 13 in HES. So anyway, just wanted to mention that. You know, and then this slide just, you know, again, this helps you sort of understand the different kind of sectors that are involved on HES collaboratives. In this case, this is our Central Providence Health Equity Zone. And you can see that, you know, we've got, you know, clinical care partners here. We've have educational partners. You can see the local school, organizations that focus on education are involved. We have environmental organizations here. For instance, Childhood Lead Action Project, addressing lead, the Woonasquatucket River Watershed Council, housing partners, agriculture and food systems, social services, economic development, parent and family organization, youth and students, law enforcement. So, you know, again, really robust coming together of stakeholders in a community to both, you know, identify problems, work together, but also leverage existing resources. So anyway, next slide. And this is Jen.
Thanks, Mia. So training and technical assistance. So the RIDOH HES training and technical assistance program is really different from traditional training and technical assistance programs, and that's because it stems from the guiding principles and the core components of the HES model. So because the HES is a community-led initiative, providing guidance and knowledge unidirectionally, like from the health department down to the HESs, would really fail to utilize the rich collective knowledge and experience of the collaborative members of the HES. So RIDOH developed sort of multiple avenues for HES training and technical assistance, with the goal of meeting the HESs where they are and in their own development process. So opportunities provided include quarterly HEZ learning communities, multiple communities of practice, project officer and evaluation office hours where they're available to discuss anything really, and the inter-cohort mentorship program. So the HEZ learning communities are centered around large meetings that allow for peer learning and knowledge sharing across the initiative, and for the HEZ collaboratives to really connect with external departments and institutions and each other. Communities of practice allow space for discussion and knowledge sharing and really learning around these common systems or impact areas like, there's an MCH community practice, there's one surrounding food systems, evaluation, et cetera. The mentorship program is relatively new in the last year, and it allows older, more established HEZs to collaborate and provide really their expertise and guidance to the newer collaboratives. And then finally, the project officers and the evaluator, myself, provide tailored technical assistance and support directly to the HEZs. And then part of that is in those office hours and making ourselves available if needed. So looking at evaluating the HEZ initiative, to evaluate the initiative, we start with a process evaluation, looking at the key elements of the theory of change. So that's, as you can see here, developing sustainable community infrastructure. So we're really using goals and performance metrics to evaluate several achievements, such as sustained, authentic resident engagement, diverse representation in community collaboratives, building a culture of collaboration, trust, and collective impact. So then if you look at aligning resources and community investments, we're evaluating the achievement of increased investment in the HEZ infrastructure. And that's both state agencies and external and community investors. And then finally, in order to demonstrate impact on health equity and social determinants, we assess the alignment of the HEZ activities from the action plans that they developed with statewide health equity indicators, which I'll get into in a second, and we track these indicators over time. To do this, we focus on tracking each HEZ's community priorities and action plans, programmatic outcomes, policy and system level changes, and performance monitoring. So we do this with a really pretty diverse variety of data collection tools. So they're using surveys, interviews, the needs assessments that were done at the HEZ level, their action plans, evaluation reports, and quarterly and annual reporting that are submitted by the HEZ to RIDOH. All of these tools are using both qualitative data to explore the needs, raise up the voices of the communities, and describe the impact of the activities within the community and their residents, really using that rich narrative data, as well as quantitative data to measure outputs and outcomes related to the action plans. It's important to remember that gaining and sharing this information is really critical to community empowerment, collective impact, and meeting the goals of the initiative. So knowledge and data sharing is a key component of an equity-focused evaluation process, and we really strive to highlight that. So this type of process evaluation is really effective at demonstrating the local outcomes and impact, but it doesn't really show very easily anyway that high-level statewide impact of the HEZ initiative. So far, the evaluation of the HEZ as a relatively young initiative has really been primarily process evaluation driven. But now that we have several years of data, we're making progress on statewide level outcomes that are geared toward demonstrating the potential high impact of the initiative. So to evaluate this high level impact, we're turning back to the model, and we have those designated 15 health equity measures, and they're separated into 5 domains. As you can see here, these include integrated healthcare, community resilience, physical environment, socioeconomics, and community trauma. So these are measured using quantitative data over time. So to give an example, if we look at the first pillar, integrated healthcare, it's measured using 3 metrics, as you see below. The first is healthcare access, and that's taken from the Behavioral Risk Factor Surveillance System, which is a national data set, and that is in the % of adults reporting not seeking medical or dental care due to cost. And then it's also measured using social services, which is a ratio of the number of individuals receiving SNAP benefits to the number of eligible recipients of SNAP benefits. And then lastly, in that pillar, we're looking at behavioral health. And for this metric, we use a ratio of the number of naloxone kits that are distributed by the number of overdose deaths. And wherever possible, all of these data are stratified by race, ethnicity, some by town, income, et cetera, whatever really is logical for the metric that we're looking at. Now, some of these measures are not assessed annually and some are. So the ones that aren't assessed annually really kind of lack adequate data at this point, and it makes assessment a bit slower over time. But those that have the annual data are really showing some insight into this high level impact that we're looking at. So it's an ongoing process. You know, all of these health equity measures are tracked and compared over time, and the process evaluation, including those HEZ level measures, like the community members that are served and associated outcomes, and demonstrating and describing the impact at the HEZ level, are sort of aligned with evidence of improvements in these statewide health equity measures. And this really supports evidence of a positive statewide impact of the implementation of the model. But obviously, evaluation is a work in progress, and the more we're really kind of looking at more advanced statewide evaluation processes that will be used as sort of like an additional means of demonstrating the impact of the initiative overall. So I think that brings us to the end. We're back. So I hope we've provided a pretty clear understanding of the HEZ for you. And I guess we can take any questions at this point if you have any.
All right, I guess we are all set. Thank you, Mia and Jen, for a great presentation. I hope you guys join us next year when we have this series again.
Great, thank you.
Thank you, bye-bye.
Thanks.